And most commonly people would answer that the goals are unclear and the limitations are time and lack of education. Now, where we have established this, then we should ask ourselves that what is a spiritual screening? Spiritual screening is a very, very short and brief discussion, maybe when a patient enters the hospital, to establish not only the spiritual needs of a patient, but also his or her spiritual resources. I think that much of the research and education is putting the spiritual needs and spiritual well-being out there, but I think that we miss out a big deal to activate people's coping strategies when we do not ask for spiritual resources. And something, for example, I encourage my students to ask that, what gives people power, what empowers them, and usually it is either grandkids or some activities, being outdoors, and so that would be an easy way to try to think that how can we enable this and support this, even if there are obviously limitations. And then, I think the other part of this question is that there's a serious lack of spiritual capacity in us, and what I mean by spiritual capacity is this space within ourselves, where we ask ourselves how are we doing today, and what can we do for ourselves to be the best me, and also about our relationships with other people, valuing these relationships and working on those relationships, and looking at and evaluating where we are at. Because if our relationships are broken, we do not have capacity to support, for example, our clients or patients. And third is the certain fear in many that there is this transcendent or theological realm of spirituality, and if we go there, we don't know what answers to give. But yes, people might ask that why does this happen to me, and why God is sending me this suffering. But they rarely look for clear answers. They look for someone who has the capacity to be present and pay attention to those questions. I think that it is too much to expect that nurses take the spiritual history. Really, it is not their task. Spiritual history taking is more for allied professionals. For example, a psychotherapist can do it very well, or a physiotherapist even. So people rarely expect from nurses spiritual history taking. But I would like to suggest this kind of very straightforward spiritual history taking or assessment that has been promoted by Wilf McGerry and Linda Ross, which is this 2Q SAM, and which my nursing students find very good, is that so what do you need today, and what can I do for you? So, and this is a good thing. Patients really appreciate it, and you can go from there. So the example would be that patient feels that he or she cannot be compliant patient anymore because he hasn't been outside for a while, and this makes him or her absolutely mad, and he just wants to get out. And so enabling this going out would be like something that would be expected from nurses, and then we have a compliant patient again at our hands. But for this, as I already mentioned, the listening and learning or understanding the words that the patient is using and the hints and clues, sometimes we shouldn't read too much into the cues, that we see around the patient. Nurses are very good in that, but really listening to the words. If a patient says she or he is drowning, this is a very serious message. So we should, or even if we ourselves feel that we are drowning, so we should work with that. And so it is a linguistic quality. The question is, so what do we do with it? So do we document it? And what about vulnerable patients with whom we cannot communicate really? There are many loose ends that still need to be tied up, and the tendency is that this spiritual history taking goes into volunteers' hands, which is not a very good trend, I think. So it should be healthcare professionals who have the duty also to elicit spiritual histories and make a plan accordingly. And I think that concentrating on resources, understanding what has been helpful before is essential in these discussions. So what has worked for you previously in previous critical situations? And then thinking, how can we enable it also? Is it a visit from someone? Is it some sort of activity, a phone call perhaps, or just, sleeping, letting the patient sleep so they can really rest. And sometimes presence is needed, that the patient can fall asleep because they might be so distressed. And so it is something which is very difficult for us to do, just to sit there and do nothing. Of course, whatever our reasoning is for doing the spiritual history, eliciting a spiritual history, tapping into persons' spiritual resources, it has to have a follow-up as well, because things happen. And when we knock, I always say that spiritual screening is kind of knocking on the door, and then later we say in a very medicalized setting, we say that it is also okay to talk about spirituality. And so it is not necessarily this person who does this work, but it might be someone else in a team, for example, who really is invited to step in. And if this happens, of course, and a discussion evolves, it is always good to have a plan for a closure or a follow-up, and to see that where the patient is at, and not that we are making the vulnerable person even more vulnerable. So because it is a morally challenging situation if we say that, we now do this screening and people open up at some point, and then again nobody cares. So there is a fear that it can cause a moral injury, and of course we know how serious the consequences of a moral injury can be, and we definitely don't want to take our patients there. So like a surgery that is done on your body needs a follow-up, also the spiritual assessment, screening and history taking, where you open up someone's soul, mind, and emotions which are difficult to tolerate, then it is our utmost duty also to see that what sort of what we can do to at least make a short closure and send people off so that they are strengthened and not even more broken because of what we have been doing and how we have been acting. So thank you very much, and I wish you a nice day.